Well, welcome everybody to our next installment of the Up to the Minute in Clinical Care series. We're very excited today to have three phenomenal speakers from the Orlando Health Organization in town. These speakers represent acute care leadership and clinical COVID care within the Orlando Health System, coordinating with their medical staff, physicians, and nursing, and other professionals from the onset of the pandemic and the continued modifications necessary as our understanding of COVID care has evolved. I'm going to spend just a few minutes introducing everybody. First, I want to introduce Stacy Perez, who's a speech language pathologist at Orlando Regional Medical Center. She has 7 years experience with adult acute care and trauma populations. She has served as the primary speech language pathologist on the COVID-19 team at ORMC, and she recently presented at the Orlando Health Grand Rounds COVID-19 program. She is a proud alum, and we're very proud of her, that she graduated from the University of Central Florida in 2013, and her passion is helping people and positively impacting their life as a result. So welcome, Stacy. Katherine Johnson.
Hi, thank you so much for having me.
Thanks for being with us. Katherine Johnson is an occupational therapist at Orlando Regional Medical Center who graduated from Nova Southeastern University in 2013. Katherine has been practicing primarily in acute care since 2014, with experience in the NICU, pediatrics, adult acute care, as well as the inpatient rehabilitation program. She has been the primary occupational therapist servicing the COVID population at Orlando Regional Medical Center and took on a leadership role amidst the pandemic in order to better serve this population. She has also taken an interest and led initiatives for sexual education at Advent Health inpatient rehabilitation. Katherine's primary goal is to ensure that every person is given the best opportunity and guidance to living a meaningful and healthy life. She enjoys constantly learning and getting to see OT across the lifespans. And Joanna Keogh is a physical therapist at Orlando Regional Medical Center. She has 3 years experience in the acute care setting, mostly with trauma patients and patients in the ICU. She served as the primary physical therapist on the COVID-19 team before its expansion, working closely with occupational therapy, speech language pathology, nurses, doctors, and case managers. She collaborated with therapists across the continuum of care, creating a poster regarding the interdisciplinary approach to treating patients with COVID-19 and presenting the acute care approach at the Grand Rounds. Joanna graduated from the University of Central Florida, another proud alum, in 2014 and 2017. And last, I want to introduce our very own Vickie Lewis. Vickie has 28 years of clinical experience as a speech language pathologist treating patients in the medical setting and joined the UCF faculty in May of 2020 after the start of the pandemic. And as an instructor at UCF, she prepares undergraduate and graduate students to be contemporary speech language pathologists with a focus on excellent clinical skills. She co-created a graduate course focused on treating patients recovering from COVID-19 to ensure students were workforce ready following graduation. So we're so excited to have all 4 of you here with us. I would just want to mention to all of our attendees, there's a Q&A button that you can utilize. That is your voice on this session. So any questions that arise, we will either address as we go along in the presentation or towards the end. Thank you for joining us, and to our fabulous speakers, I'm going to turn the program over to you now.
All right. Should I, Megan, should I share my screen again for this slide?
Yes, please go ahead and share your screen and run the PowerPoint.
All right. I guess in running the PowerPoint, if the speakers could just let me know when to advance the slides, that would be fantastic. And I'll put this in presentation mode.
Vickie?
Yes.
It's Katherine. I'm sorry to interrupt you. You can skip that first slide, by the way, and just go straight to the acute care and COVID-19 slide.
All right, there we are.
So because our speakers had difficulties connecting, they're just on a phone, so you're not going to be able to see them today, but you are going to be able to hear them. So we'll let them go ahead and start from here.
Okay, hi everybody. I'm Katherine Johnson. I'm an occupational therapist, so I'm going to kind of kick us off here, and we'll just start with some general education and then kind of dive into the acute care rehab team and how we manage the COVID-19 pandemic since it kind of began. Next slide. All right. So obviously we all have heard lots about COVID-19 over the past year or so. The SARS is the virus. COVID-19 is the actual infection. Not every patient develops the actual viral pneumonia. So if you see the difference, that's what it is there. So it's a respiratory virus. There's a variety of symptoms that are listed there. And obviously several of these symptoms can mimic the flu and other conditions, rhinovirus, things like that. But it is variant across who's infected. You can have fever and chills, cough, shortness of breath, fatigue, muscle and body aches, headache, loss of taste or smell, diarrhea, sore throat, congestion or a runny nose, and then nausea and vomiting. So like I said earlier, there's a wide presentation for these patients. You have some that are asymptomatic where they wouldn't even know that they had the infection. And most of those patients or family members only get tested if they knowingly ran into someone who was positive. And then you have the severe infections. And obviously the severe infections are the ones that we tend to see here in the hospital because it requires more care than what they can do at home. So for our patients who do have the more severe infection, the average time for acute respiratory distress syndrome, that's the ARDS, is about 8 to 12 days after the onset of the illness. And that doesn't necessarily mean 8 to 12 days after the exposure because symptoms tend to not even present themselves until about a week or so after the exposure. So it could be more so like 3 weeks after the exposure, but 8 to 12 days after you start getting your symptoms. And about 26 to 32% of the hospitalized patients are admitted to our ICUs. So that's about a third of the population in the hospital ends up in the ICU care. These are just some stages of the virus. You have the early symptoms, so that's no hospitalization required. You kind of monitor yourself at home. They'll have patients come into the ED with the shortness of breath, the cough, the fatigue, and if they are okay with their oxygen settings, so they're able to maintain in the 90s, typically they'll send those patients home, tell them to get a, not a spirometer, what am I saying? A pulse ox. Thank you, a pulse oximeter so that they can measure their oxygen, and they'll only tell them to come back in if their oxygen levels significantly decline, like they go below the 90s. So those patients are often able to go home as long as their oxygen is stable. Then you have the respiratory distress. That's typically when they will be admitted and they might require some additional oxygen. Stage 3 is the respiratory failure. So that's where we'll see them in the ICU, whether they're intubated or they're on another form of respiratory support, which we'll kind of get into in a little bit. And then there's that post-acute care recovery. So when the patient's discharged from the hospital or they discharge to inpatient rehab and they kind of start their moving forward and trying to overcome everything that's happened during their hospital stay. Next slide. So these are just some things that we see during our chart review as far as how they diagnose COVID-19, because there's not just one way to diagnose it, although testing is one of the primary means, and then also the treatment. So for some of our testing and imaging things that we look at, there's the rapid test, which the test comes back in about like 15 to 20 minutes, and it's to detect the proteins that are in the virus. Our tests tend to be very sensitive here at ORMC, so people may test positive for a very long period of time. We'll get into that more as to why that's relevant for this population and how it's changed their care throughout the pandemic. And then you have the PCR test. It takes longer, usually about 48 hours or so to get the results back. And that is kind of the gold standard for detecting COVID-19. It detects the RNA of the virus, and you can have that detected within days of infection. So it tends to be a little bit more accurate getting the PCR test. Now, recently, in the past several months, we also have serology testing. So that's blood work to detect if there's antibodies in the bloodstream, and that's to identify whether it's an old infection or a new infection, because some patients may test positive, but if they have the antibodies built up in their bloodstream, it's more likely an old infection that's no longer active, rather than an actual new infection that could potentially spread to other people. This is an actual chest x-ray. Obviously, the name and patient information is not on it, but of what a typical patient who's developed a viral pneumonia might look like from COVID-19. So you get those ground glass opacities, you get the airspace consolidation. So that's pretty typical. And the chest x-rays will look like this for weeks with some of these patients. The patients also might have an elevated D-dimer, and that's associated with a greater risk of death. And that D-dimer is how much your blood is kind of coagulating and clotting. So typically we have about 100 to 250. And with these patients, we're seeing in the thousands. So 10,000, we had a patient in the 30,000s. It's very elevated, which is also why strokes are such a risk factor, and pulmonary embolisms and DVTs and things like that for this population. Then you have the prolonged prothrombin time, which is the time it takes your blood to clot, the thrombocytopenia, which is the low level of platelets, and then lymphopenia, which is your level of lymphocytes. And that's an important component in your white blood cells that allows you to fight infections. So if you have decreased lymphocytes, it's harder for you to fight off any kind of infection. In the beginning of the pandemic, we did see a lot of early intubation with these patients. That has since changed, but very quickly the patients were being intubated, and that did result in a lot of a higher level of death in this population, because it was very difficult for patients to come off the ventilator. They also use the hydroxychloroquine and the cefepime. The hydroxychloroquine and cefepime were kind of experimental. So obviously this is a new virus. No one really knew exactly how to treat it. So we were just kind of trialing everything. Doctors across the world were figuring out what to do. So hydroxychloroquine was used for malaria and lupus. So they were just trying it out. It's an anti-parasitic. And then the cefepime is for bacterial infections. But they found that those are obviously not very helpful against this virus, so they don't use those anymore. Now also they tend to do a combination of respiratory support instead of early intubation. So we'll see patients who are on OptiFlow, which is a heated high flow nasal cannula. It has the capacity to deliver about 60 liters at 100%. And some of the patients will even have a non-rebreather mask on top to try to see if we can prevent them from being intubated, because we all know that it's more beneficial if patients can be alert, awake, and able to avoid that ICU delirium, avoid, the additional sedation medications that an intubated patient may need, and allow them to be a little more mobile. So a lot of patients will end up on those OptiFlow supports. Then there's also the convalescent plasma. So survivors of COVID-19 go donate their plasma, and then that's given to the patients to try to see if it will help them overcome the infection. Vancomycin, which is an antibiotic, they've been using that. The dexamethasone, which is a corticosteroid, they get a high 10-day dose of that. The remdesivir, which is an antiviral, they get a 5-day dosage of that medication. Prone positioning, so for our intubated patients, they do typically not only prone them, but put them on paralytics to prone them. So it's very common for them to be on a proning schedule in the ICU. And then we do encourage our patients who are not intubated to self-prone if they will tolerate it. It just is shown to help with the lung support and, allow them to oxygenate a little bit better. The more severe patients, we have had a few end up on ECMO, and they've been doing the femoral cannulation here primarily. So that's kind of a last resort in order to give the lungs a rest, and then the ECMO pump will circulate the blood for the patient. There's also a couple new developments. So the monoclonal antibodies, they have started doing that, not here, but we've had patients come here who received the antibody treatment at Advent Health, and then some of them, it helps them overcome the illness, and some of them still have difficulty. So we've had some patients end up here who did receive that treatment, but the goal is to help your immune system fight the virus if it's a new infection and it's early on. So the earlier you get the antibodies, same with the convalescent plasma, the earlier you get it, the better. And as we all know, it's not really a treatment so much as an attempt of a preventative, but there's now the vaccinations available. So Pfizer and Moderna have both been approved. It's a 2-dose that you get the Pfizer, it's a 3-week apart dosage. And then if you get the Moderna, it's 4 weeks apart. Much of the staff here at Orlando Health has been vaccinated. The 3 of us have been vaccinated, and obviously it's a personal choice for everyone, but we're just hopeful after seeing everything our patients go through, we're hopeful that it can help them. Does anybody have questions about anything that I discussed?
Actually, there are 2 questions there. And so we have, do you see enlarged lymph nodes or lumps in the neck with COVID?
That's not anything that any of the doctors have noticed or that I personally have seen. So not that I am aware of, no.
And there's another ask, is there an antibiotic for people who are allergic to Vanco?
That would be a fantastic question, probably best suited for our infectious disease team. I am not as familiar with, a replacement drug for a specific antibiotic. I haven't seen any other antibiotics for the patients listed. So yeah, they haven't really been doing this too much. Yeah, they might be.
And can you define prone positioning?
So prone positioning is when you are on your belly. So typically it's like a swimmer's position, when you learn the typical breaststroke where one arm is forward while the other arm is back. You'll be on your belly. They'll have pillows underneath the arms, under your head. Your head will be rotated towards the arm that is forward overhead. And then they'll usually put pillows under the legs and sometimes underneath the hips as well, just to prevent any kind of like back pain and things like that.
So that's that picture on the bottom right is someone in prone position.
And then one last question regarding the vaccine. They're asking, is there a length of time that it's supposed to last?
As of right now, the vaccine is still being developed. Research is still being done. They're trying to play it on the safe side. And for now, they're giving us like a 90-day kind of guarantee that we'll have that 95% immunity to it. Now, again, that doesn't necessarily mean you can't get the virus and have an asymptomatic infection and spread it to someone else. There's still, again, research being done about that, but they're hoping that it's at least 90 days of protection, which is 3 months. But because the vaccine is so new, they're not certain if it's longer or what kind of length of time we're looking at. So there's more to come with that. There's more vaccines being produced. So we're kind of going to be learning as we go, just like the rest of the country, as far as the effectiveness and the approval of all the vaccines out there.
Okay, great. That concludes the questions. You could go ahead and move on to your next slide.
I've lost my icon to advance the slide at the bottom of the screen. There we go.
There it is. Yeah. Okay, so first I'll just kind of touch on the pictures a little bit before I get into everything else. These are just some of the signs that we'll see here in the hospital for our COVID patients. They are on specific isolation protocols. Now, the CDC in October did establish that COVID is more of an airborne. So you do see the droplet in contact and then the airborne in contact. The rehab department has always worn airborne protection with our COVID patients just because of the length of time that we're with them. They're usually coughing. We're very close to them. So just for our own safety, we typically wear the airborne PPE, which is personal protective equipment. So whenever you see these signs on the door, that's how we identify it as a COVID room. The airborne rooms are patients who are on the oxyflow, which is that heated high flow nasal cannula, or the patients who are intubated. droplet is for patients who might be on room air or just a regular nasal cannula. But again, we just wear the airborne protective equipment. So we'll wear either our North respirator mask, which is kind of like that Darth Vader looking mask. I don't know if any of you guys have kind of seen that in some of either the news channels or things like that. And then there's also disposable masks that you can wear, which is the duckbill or the medical mask, and those are fit for airborne rooms. Then we also have to wear eye protection, hair nets. Obviously, we wear gown and gloves. We used to wear booties on our feet at the beginning, but infectious disease actually preferred, as we learned more, that we do not wear those. So we don't wear any coverings on our feet. And then obviously, you know, for each patient, we have to don new PPE unless you're going straight from one COVID positive room straight next door to the other, meaning you're not going to have a lot of traffic in the hallways or anything like that. You can keep your same mask and your hairnet and eye protection on, but you still have to change your gown and your gloves. So our first patient that we treated as a team was actually back in April. The patient was a physician who ended up on ECMO and was intubated for about 7 or 8 days, I believe. And that was the first one who, during rounds, Joanna was with the medical team, and they just kind of realized, yeah, we have to get in there. And since then, we've had thousands of orders. We've had several patients come through the hospital. At one point, there's 20 nursing units in the hospital, and at one point there were 8 floors filled with COVID patients. They had to transition normal patient rooms into negative air pressure rooms and put these large vents in. So we had to empty out our typical floors in order to construct them to be appropriate for our COVID population. And at one point, in addition to the fact that it was 8 floors, 2 of those floors were double occupancy rooms at one point. So it was a large portion of our hospital population at one point. Some of the things that were a little difficult during the pandemic was the fact that our policies and procedures changed often. So in the beginning, we were supposed to wear this kind of PPE, and we were supposed to do this kind of safety measure. And then as we learned, things just kept evolving and changing. So that was definitely one of the difficulties treating this population. We were learning something new every week, every day. Things from floor to floor weren't always the same. So it was just kind of trying to keep communication open and streamlined across everyone. We had to kind of also work on when do we initiate services for PT, OT, and speech, and when do we know when to step in with this population. We changed how soon we go in there as the pandemic progressed. We were waiting until patients were less than 60% FiO2, as we tend to do with many ICU patients. But because the COVID patients are sometimes on that OptiFlow, which can go up to 100% FiO2, we started intervening even earlier with those patients who were not intubated, but still on that high level of support. And then there's also just the isolation for these patients. So the patients are very socially isolated. They were not allowed any visitors. So I think August is when they started allowing one visitor for a short period of time. But so from March until August, 5 months, none of the patients could have visitors. There's no music therapy, no pet therapy. Not many people go in the room. Several physicians will just examine the patient through an iPad communication system. So rehab, I think, had a very special role because we don't have, I wouldn't even like to call it a luxury because I think in-person is always better, but we don't have the luxury of doing teleservice, like telehealth service. We have to go in there with these patients in order to safely care for them. So I think our social interaction and our ability just to have that in-person time with them was really helpful for them. And it was actually just kind of renewed, I guess, my passion for treating patients in the hospital, just seeing how helpful it can be for people like that. So I'm gonna hand it off to Joanna so she can kind of go over the de-isolation protocol that they established and then get into some of the therapy. Okay, I'm sorry, I'm going to go over the de-isolation protocol. All right, so the de-isolation protocol was established in August. So you can see there, August 26, 2020. So because of the fact that patients were testing positive for months, I mean, we had patients at the beginning of the pandemic, they were here for 2-3 months because they continuously tested positive. They couldn't go to a skilled nursing facility with a positive test. They couldn't go home because their family members would be scared to take them. They couldn't go to inpatient rehab. They were just stuck here in the hospital for a very long period of time testing positive. Patients couldn't have surgical procedures because they were still testing positive. So it really was a big burden for them. So as more research came out and infectious disease really investigated how necessary is it for these patients to stay isolated the way that they are, and what is the risk that someone else could contract the virus from someone 2 months after they initially get it. So after research came out, they realized that if a patient has asymptomatic or a mild, moderate illness, meaning they don't require ventilator support or the OxyFlow, they're not significantly ill, that they can be on just a 10-day isolation. So that means they're in an isolated COVID room for 10 days, and after that, they go to a regular floor. They're treated like a regular patient. That's our hope anyways. And again, as long as they don't have a fever or any significant change in their symptoms, as long as they're stable and it's been 10 days since the initial positive test or the initial onset of symptoms, they can be what we call de-isolated, so move to a regular room. But if you have the patients who are severely ill or immunocompromised, so any oncology patients or patients who require the intubation and things like that, it's a 20-day isolation, again, pending that they do not have a fever or any change in symptoms during that time. So that's kind of how our patients were able to eventually transition to normal care and just go to a typical room instead of for months at a time being kind of stuck because of a positive test. So a positive test doesn't necessarily mean you have to be isolated and that we have to wear the PPE. It really depends on where you are in your infection, whether it was old, new, and how were your symptoms. Does that make sense to everyone? Okay. I will now pass it off to Joanna.
Okay, so now I'm gonna just go over how PT and OT approach treating these patients in the acute care setting and some of the challenges that we face with this new disease. Okay. So we have a picture of one of our rooms, which is actually kind of a bigger room than some of the other rooms. The top right-hand corner, you can see that the negative pressure air vent. So that's how the rooms were converted into airborne rooms. The only issue is it's just out like 2 feet. It's so loud. So when we wear our masks, the Darth Vader masks that Katherine was talking about, it's really hard to even hear the person talk. And then there's also that really loud vent. So we're pretty much screaming just so our patients can hear us. Once you are in the room, you're in the room. There's no like, oh, I forgot socks, so let me just run out real quick. In the beginning, all the nurses everyone was just really overwhelmed. So everyone was spending a lot of time in the room. So you were kind of like on your own once you were in the room. So you kind of had to have a list of what you were going to bring and then kind of just fend for yourself. So that's why we did a lot of co-treating as well. So in the beginning, donning and doffing our PPE took a lot of time just because it was just a new thing that we had to get used to and we wanted to be extra careful. I think we skipped a slide, by the way, Vickie, now that I'm thinking about it. Common findings, there we go.
All right.
So these patients will have a myriad of symptoms. The common ones we encounter are the ones listed. Tachycardia and shortness of breath are side effects of myocarditis, which is a common finding in patients with COVID-19, regardless of age, previous medical conditions. The fluctuating respiratory status and decreased reserves are important factors to keep in mind during therapy. One day a patient will be on room air, and then 2 to 3 days later, they are on OxyFlow, which can range from 20 liters per minute to 60 liters per minute. They're unable to finish their sentences without taking multiple breaths. Their reserves are depleted, and it makes it almost impossible to maintain their oxygen saturations at a normal level during mobilization. So we kind of have to take extra time with these patients, help them with breathing exercises, kind of help them with their anxiety as well, because understandably they are very anxious because they can't feel like they can't get a good breath. So patients will just be supine in the bed, go to the edge of the bed, and their oxygen will go from 94%, drop to 80% within a minute. And then it takes a very long time to get back to a normal range, which is 88 to 92% is kind of where our goals are for these patients. Their respiration rate can increase to the 40s, and normal respiration is 12 to 20. And then, as I said, their anxiety builds, so it just makes it more difficult and more challenging to safely mobilize these patients. So kind of just talking about the different oxygen therapies. So they'll start off on room air usually, and then 2 to 3 days later, what Katherine was saying, because they'll sometimes have the COVID disease before they even come in. So by the time they get in, they might already be in the ARDS. So they'll be on nasal cannula, and then OxyFlow is what I was saying, 20 liters to 60 liters. And then it also, you can change the delivery of the FiO2, so the concentration of oxygen. It can range from room air's 21% up to 100%. NPPV, can think of like CPAP, so it helps with that pressure support. They can be intubated as well, and then that non-rebreather is another way to just, it's a face mask with a little bag at the bottom, so it fills up with oxygen, and then you can kind of control FiO2 and the liters per minute. Another thing that we noticed is that these patients have a poor insight into their deficits, and it might just be because of the anoxic injury that they had, sitting at home for days with low oxygen levels. So they feel like they can do more than they can, and we have to kind of stop them from what they're doing, have them kind of assess the situation and give them cues for safety. Neuropathy is also a common finding just because of the critical illness that they're going through. They do have the higher risk for blood clots, like Katherine was saying, because the D dimer is elevated, so that can lead to strokes. So sometimes patients will come in with a stroke, and it kind of makes us think, did they have COVID before this? And just to be extra aware of that. Additionally, patients will present with other cardiac and neurological disorders, such as arrhythmias. We've had several patients with Guillain-Barré syndrome and acute disseminated encephalomyelitis, which is inflammation to the brain and spinal cord. Next slide. Okay, so back to barriers. So there's staffing considerations. Like I was saying, there's not a lot of availability for assistance from nurses because they were already kind of overwhelmed with their patient caseload. So when patients are very weak, in order to make it more safe for mobility, we would co-treat. So PT and OT, Katherine and I would frequently co-treat, especially a lot of the younger patients would be trauma alerts, and then they would have just so happen to have a positive test for COVID because they're going into surgery, to fix broken bones, things like that. So not only are they a trauma patient, but now they have COVID. So equipment and braces were not readily available. The company that delivers the braces, like the TLSO, LSO, things like that, don't actually go into the room. So we would go in and fit the patient, modify it, call them back if we needed a bigger size. And then the nursing specialty, they're they're getting a bunch of different types of patients, but they're all labeled as COVID. So the nurses that are usually used to just like medical patients that had simple surgeries now have trauma patients, spinal cord injuries, burns, things like that. So in the beginning, they would kind of float those nurses down to the unit to take care of those special patients. And then another thing is we have limited availability of outcome measures because we can't really write anything down while we're in an isolation room. Everything is fluctuating. It's just a very quickly changing environment. So you want to make sure the patient is safe before you try and remember any outcome measures. So that was a big limitation to that. Let's see. So discharge planning has definitely changed for the better. In the past, like Katherine was saying, patients would be stuck here for weeks, maybe a month, 2 months, just because there weren't any rehab facilities, like skilled nursing facilities that were accepting these patients because they weren't equipped for airborne rooms. So we would have to prioritize patients based off of their ability to safely progress home. We would talk to family members, make sure that the family is okay with the patient coming home, how to safely isolate from them, how to safely help them when they do return home. So Katherine and I were closely in contact with a lot of the family members. Of course, they're also concerned about getting the virus as well. So some of the family members would refuse to take patients, which, I mean, it's frustrating, but it's definitely an understandable thing in the beginning when it was such a scary thing. So visitors weren't allowed. So we were kind of the people to be in communication with the family to kind of make sure that they knew what was going on, what was happening with their family member, and maybe setting up video conferences and things like that. There was one patient in particular that was a trauma patient with a brace for his back and his neck, and he had other cognitive issues from TBI. So we went in with an iPad and basically did a video conference and showed them how to put on the brace, how to safely transfer the patient, log rolling, things like that. So that was definitely a new thing that we had to do. And then, let's see. And there was also a time where, because so many patients were going home with oxygen, that there was a national shortage of oxygen tanks. So that would also delay the discharge to home. That's not really a problem right now, but it definitely was a new curveball that we had to go through. So discharge planning now, still visitors are allowed, so it's a little bit easier, but there's still some challenges, especially if patients live alone. A lot of the patients seem to always be on the second level. So we had to be creative, which I'll kind of talk about treatment with that. But now there are facilities that have COVID units. So patients aren't just stuck here and waiting for us to kind of rehab them to safely go home. So there are the COVID units, and then also patients are de-isolated quicker than in the beginning. So patients aren't just waiting here 3 weeks, waiting for a negative test. Okay, do we have any questions before I go on?
We do have one question, and I don't even know how to pronounce this word. It says, it's interesting that patients may be thrombionic. What is that? Yeah,
Thrombocytopenic. So that's just the white blood cells.
Are you talking about the prolonged thrombin time where it takes longer to clot, but then their D-dimer is elevated, so their clotting is actually increased? That might be
that question does reference developing clots. So they just wanted to know if you have any comments around that.
Yeah, I mean, as I was doing research and things, that definitely stuck out to me as far as the fact that D-dimer is elevated, which means your clotting factors are higher, but your prothrombin time is also increase, which is the time it takes for your blood to clot. So it's actually saying that your blood is clotting slower. So it's kind of contradicting itself. Yeah, I definitely found that very interesting. I have to look more into that as far as the fact that those two things can happen simultaneously. But the D-dimer being elevated is definitely more common in the more severe illness. So the prothrombin time is found more so in the patients who have mild or moderate illness. So it is a little different based on the severity of the patient's illness from what I've seen anyway.
All right, that's all. If you want to continue on.
Okay. So treatment sessions are tailored to each patient's needs and presentation. Like Katherine was saying, we educate patients on self-proning just to improve perfusion to the lungs and opening of the alveoli. The incentive spirometer is also very helpful for these patients, along with breathing exercises to help them perform diaphragmatic breathing instead of using all their accessory muscles. So that helps reduce their respiration rate and usually helps reduce their anxiety. We would perform endurance tasks, which when I say them to you, you're going to be like, that's nothing. But when patients are already a 7 out of 10 laying down, when they do small little tasks, it's kind of a big thing. So we would work on unsupported sitting, static standing, weight shifting, transferring to the chair. Sometimes that would take 10, 15 minutes just to go from laying down to sitting in a chair, just because of the things I was mentioning: heart rate, oxygen levels, respiration rate, anxiety, everything like that. Sometimes the patients can only tolerate standing for about a minute before we need to cue them to sit down, because those vital signs are a concerning factor. Muscle fatigue would also set in, especially if they were on paralytics or on sedation for a while. I was talking about stair training earlier. So you're obviously in an airborne room and you can't leave. And so it's hard to kind of simulate stair training. So what we would do is we would go into the bathroom. There's a walk-in shower with a ledge. We would use that ledge with the grab bars in the shower just to kind of go up and down that ledge to work on that endurance and that strength to make sure it's safe to return home. For the patients that were on paralytics or had the diseases like Guillain-Barré, things like that, demyelinating disease, we would use a standing bed frame so they wouldn't have to waste their energy getting to the edge of the bed and us standing them up. You could just kind of strap them to the bed, stand the bed up. They would have that benefit of weight bearing through their legs, and then you could work on other endurance activities and ADLs. So that's definitely been a huge lifesaver for us. We became more aggressive with ICU mobility. So normally your cutoff is FiO2 of 60%. So how much oxygen concentration you need in order to maintain your oxygen levels. So we actually would see patients with higher levels of FiO2. And sometimes we would have to pre-oxygenate patients. So I had one doctor before I went into a ventilated patient that he just increased it to 100%. So they're completely maxed out on the ventilator. And he's like, all right, do your thing. So we would work on just, like I said, sitting, getting to the chair, small tasks like that, which are actually a huge accomplishment for these patients. And then because of the paralytics and the neuropathy and the demyelinating diseases, some of our patients would have foot drops. So they would need AFOs in order to make sure that there is safe ambulation and to help with that endurance and all of that. Okay, and then next slide. So overcoming challenges, it was definitely useful to have a small team in the beginning just because of those day-to-day changes. Sometimes there would be one policy put in place, and then at the end of the day, it was a completely different policy. So we wanted to just kind of, we were the guinea pigs in the beginning just to make sure that everyone would be safe once the policies were established and had been in practice for a while. We created a COVID specialist position, which Katherine has championed, and she would go through the list each day and prioritize patients as needed, make sure that patients weren't falling through the cracks, because sometimes they would be so sick for so long that they weren't appropriate for therapy, and she would see when they were finally appropriate, and we would go in and start working with them. Communication between PT, OT, and SLP was key. We would go in and kind of see if there was any cognitive impairments or notice if a patient was coughing while eating and drinking, especially when they're on that high flow nasal cannula. So then we would consult the SLPs and have them go in. And then the beginning, we were receiving so many orders and we were worried about the PPE supplies. As you guys know, there were some shortages in other areas, thankfully not here, but still it was definitely a concern. So we had to, that's why most of the reason why we had a small team, just so we weren't going through PPE for just any patient that had COVID. If they just had mild flu-like symptoms, there's no need for them to get therapy. They can safely return home. So we had to go through those orders and see what patients truly needed therapy. And then constant communication between the nurses, the doctors was definitely necessary to ensure safe discharge and discuss the patient's needs. Sometimes that included medication like gabapentin for that neuropathy, or even anti-anxiety medications. And then if we notice that patients with cognitive deficits, we would definitely discuss the safety concerns with the nurses and the doctors and emphasize need for bed and chair alarms, because some of the rooms didn't have windows and they would obviously have to remain closed to keep that airborne room. So sometimes the patients were just walking around the room. One patient fell and was bleeding and no one knew until Katherine went in and was like, "Why are you naked and bleeding?" So definitely a difficult thing to get patients to just sit in a chair, stay in the bed and not get bored and try and walk around and do all these things that they shouldn't be doing. And then above all, our adaptability and flexibility to these situations, I think, is what allowed us to overcome these challenges as a team. And I'm definitely grateful to my COVID team. All right, so now I'm gonna pass it over to Stacy.
Vickie, how are we doing on time? Because I know we had a little bit of a late start, so.
It is 12:53 on my clock. Hoping to wrap up. Do you think maybe 5? And then take some questions?
Yes, I can talk fast.
Okay, maybe we can.
Certainly, do what you need, Stacy.
Okay, thank you. Hey, I'm Stacy. I'm the speech pathologist here at ORMC. Do I have control of this? No. Oh, okay. Okay, so this is an outline of the aerosol generating procedures we had. So initially, speech pathology was completing telehealth practice for clinical bedside swallow evaluations. The SLP, our lead SLP, was instructing the nurse how to complete the Yale swallow protocol, which is a swallow screen. It's a pass-fail used to identify those who require comprehensive assessment of swallowing, and it's a 3-ounce water swallow challenge. So the SLP was telling the nurse over the iPad how to do it through the window. However, this was no longer sustainable. The larger we got, the more the numbers started to increase. So we established a small COVID team to reduce foot traffic within the department. However, that didn't become sustainable any longer. So now there's a total of 12 of us seeing COVID patients. And then you can go ahead and change the slide. So here is an outline of some common findings. Current data shows that a majority of COVID-19 patients admitted to the ICU require mechanical ventilation. As SLPs, we can apply our existing knowledge related to dysphagia in the ICU to COVID-19. We know that critical illness and intubation can increase the risk of dysphagia. Our initial thought process always has been high flow equals no-go. So when we see someone on that higher rate of oxygen that Joanna was talking about, we put a hard stop to that. Significant and prolonged respiratory compromise causes difficulty coordinating breathing and swallowing to protect the airway. If the person is working hard at breathing with a respiratory rate over 25 to 30 breaths per minute, they may have a hard time squeezing in the swallow. We cannot breathe and swallow at the same time. So with all of that in mind, patient selection is key. We know longer intubation can increase the risk of dysphagia. We know that elevated respiratory rate and the abnormal breathe-swallow coordination can increase the risk of aspiration for both the healthy and disordered population. It was imperative that we looked at each patient's general picture to determine and assess the aspiration risk and dysphagia management on a case-by-case basis. So that oftentimes meant initiating diets on a high flow of O2, which forced us to change the way we critically think about the symptoms of COVID-19 and the supportive therapies and how this might or might not impact the swallowing and aspiration risk, including newly established, including in-room modified barium swallow studies. So we were going in the room with the C-arm when some of these patients were on that high rate of O2 to try and figure out how are they doing with their breathe-swallow coordination. There was an instance where, you know, some people are doing fine and we can say, yes, go ahead, have a regular thin diet, but we still always check them. There was one instance where we initiated the gentleman on regular thin, and then the next day, unfortunately, he did have to be intubated. So it just showed that he was having a harder time than we thought. And oftentimes I ask the nurse, how are they doing on that high rate of oxygen? And they'll just say, oh, they're doing fine. But you know, they're not eating that much. And so for us, we have to critically think, okay, are they not eating that much because they're having trouble coordinating? And when you have something blowing into your airway, it's hard to close off that swallow, which, you know, in turn turns off eating. So let's see. So we also try and ask the nurse, can they improve within the next day or two? Can we try holding off? Can we drop a DOP tube? Are we weaning them down today, or what's going on in that regard? So similarly to many of our typical patients in the ICU, patients with COVID-19 may develop neurological symptoms such as delirium and altered level of consciousness. There were a few patients that ended up needing to be trached, and those patients were provided a communication board to allow them to communicate. One patient specifically required the use of an AAC device, so she got a Toby. We got approval from the management team to allow us to take that device in the room because, again, there's always the concern about contamination, but she needed it. She was younger. She was provided with room signs for immediate direct selections, 4-quadrant alphabet boards to use eye gaze and the Toby. She was so incredibly thankful for this. She said no one had ever taken the time to do this with her. She expressed gratitude for it all. She was able to get her concerns out about her medications, her status and symptoms, plan of care, overall recovery process, things that she had been wanting to know for weeks, but couldn't express that. So it was pretty nice to see how she was able to finally communicate how grateful she was to that. Something so simple, giving that back to her was amazing. But overall, these deficits impact safety and inhibit progress in rehab and pose a barrier to independent living. Let's see, I think we can go to the next slide. Okay. Due to the telehealth practice, speech involvement was initially reduced. This was a common misconception that speech did not see COVID patients. That was not the image that we were trying to portray. We were just trying to be mindful of what was going on. Oftentimes we were not consulted, or we were waiting to assess the patient, which they didn't know that we had the consult, but we're waiting to assess just because of the high level of supportive therapy the patient was receiving. Catherine is amazing at getting us orders. She's like, I don't know how you guys aren't involved, but you need to be involved. So in terms of the modified barium swallow study that we would do, multiple therapists were required to assist with the MBS. So one person was a feeder and the other person was recording with the iPad. There's a limited availability to use specific assessments. So, you know, it's hard when someone would come in with a mild TBI. We weren't able to use one specific assessment, the Cognizant, because it has so many manipulatives that we didn't want to use it due to the risk of contamination. So there is the negative impact of mask, as Katherine, Joanna have kind of touched on. Mask speech, specifically for speech therapists, makes it difficult to understand us because oftentimes we're trying to ask them to complete an oral motor exam. So asking someone sometimes to stick out your tongue is a little bit harder than we imagine. They don't really understand what we're saying, and they rely on that visual cue. Puckering your lips, that's a troubling one as well. So not being able to have that was challenging. You feel like you're shouting at the patient. It's specifically hard for those hard of hearing patients. I had a gentleman that had a cochlear implant and a hearing aid and my mask. It was a zoo. So another new barrier that we recently encountered a couple weeks ago is PEG shortage, which we did not anticipate, but a lot of people, because they're being mechanically ventilated and then they're being trached and then their swallow is just a mess. You can't keep the Doppler tube in for too long, so we needed to talk about other options. So that's putting in the PEG, but there was one instance a couple weeks ago where they had to hold the surgery because the PEG tubes, they were out and they had to wait for that. So like Joanna said, noise interference is really tough, especially when we're recording for speech therapy, because if someone's on the opposite side of the C-arm and you're trying to shout to the front of the room, you can't hear a thing. It's just very noisy. It's just like a constant fan, and the patient can't hear you. It's really tough. Radiology in our hospital system wide requires COVID testing for every patient, regardless of the patient's admitting diagnosis. So if you were to come in with a car accident and nothing related to COVID-19, you still require a COVID-19 negative test in order to get a modified barium swallow study completed. This is also included for outpatient modified barium swallow studies. We also had some incidental findings of about a handful of patients who were positive and then would eventually transition to our COVID floor, which then would delay them getting to be able to eat and drink, because now we have to do an in-room modified, which we didn't anticipate for that day. There was a decision tree to determine when and if the patient could go. This was way back in the beginning when we didn't really know what was going on with COVID. Now it's just the current policy is COVID negative ×2, and they are free to go to radiology without question. And I am ready for the next slide too.
Can you quickly define
so
PEG for the audience? What is PEG?
It's that tube that goes into your stomach, the gastric tube. Hold on.
It's a pericutaneous
It's a feeding tube.
endoscopic gastrostomy.
Thank you. Mouthful. Okay. The pressure. I'm trying to speed. Sorry. Okay, I forgot I had this slide in here, but this was the decision tree that we had to go through whether or not we were going to see the patient. If you can look at the date, it says June, which is crazy to think that it was that long ago. And then you can go to the next slide too. I think there's another picture there too. Yes. So this is the COVID testing for modified barium swallow study. So this is the last policy was September 14th, and the stack that we have in the office from when it first started in March to now, I think this was the one that is like the final one. We haven't really had a change in that. Another one of the things is for de-isolated patients. Oh wait, you can go to the next slide. Sorry, Vickie. How am I doing on time? Ooh, okay. So this is what it looks like to go into the room. This is the C-arm machine. So this device is like a rainbow and it goes over the patient. We have had patients that are very fearful of this device. Keep in mind, delirium, isolation. We had one woman that we were trying to do a modified on when this came into the room, and it scared her that, you know, when you have an anxious person and you're trying to feed them and they're anxious, it's not a good look because it changes her swallow overall. And we were unable to even complete it because she just started vomiting. She couldn't keep going with it. So double occupancy rooms were a huge challenge in the beginning. We don't have as many double occupancies anymore. I think it's just because I don't want to say that the numbers are low, because that's not the case, but in the hospital system, each patient is able to have their own room that we don't need to have a double occupancy room. But when this was the case, we had to figure out when it was a lot of moving parts. We have to get a patient out of the room, put them in a room that they're available in. It has to be male, male, female, female, and switching. It was a challenge. The analysis of the video became incredibly hard. The quality of the video made it difficult to determine timing. There's a whiteout effect that happens when you use the iPad and record it on the little TVs that you see right there on the screen. When I'm holding up the device, or when you're holding up the device to that screen, there's a whiteout effect, which it always happens to be right where someone would potentially be penetrating with their liquids, of course. So it was helpful to have the other SLP present in the room because we were able to kind of communicate. We know our language, but when caseload was very high, we used OTs and we used PTs, and that was a little bit of a challenge because they're not familiar with the language that we need to kind of get these to do this evaluation. So what does this mean for de-isolated patients? Unfortunately, if it has not been 90 days since their last positive result, they're unable to be retested due to the restricted testing period per the hospital policy. So in essence, we're treating them like they're still a COVID positive patient, even though they're not. And I think you can go to the next slide, Vickie, please. So we overcame lots of challenges. So nursing education, the stronger presence meant more consults and better outcomes for patients. Another challenge we overcame was being creative with the assessments. You can see we're taping things up on the window so we can get the results that we need. COVID has become a new way of life in the acute care setting, and I have to say I have the most supportive speech team as we navigate this. Yesterday alone, we had 3 COVID modified, so that's 3 SLPs that are doing it, but we need 3 additional SLPs, so a total of 6 staff members are going into all of these, and it's 2, 2, 2, 2, and it's a challenge, but we all do it with a smile, and you can't do it without support. So thank you to those girls that are listening. I think I'm done. I'm sorry.
Okay, I'll just wrap this up really quickly because I know we're running a little bit over. Thank you, everybody, for being patient with us. You can go to the next slide, Vickie. So just a few things and updates as the pandemic has gone on. PPE has not since been an issue. We have plenty on board. So, because there was a point in time we had to wear the same mask for a week, and now we can wear a clean mask every day, which is great. So PPE is no longer an issue. Rehab started to participate in the safety officers meetings, which is where they would discuss any policy and procedure changes throughout the hospital system. They developed COVID designated SNF placement for our patients who require rehab, but they are still considered infectious. And they also actually developed a COVID hotel because we did have a homeless population of COVID patients, and we don't want to send them to the street where they can infect other people and lead to more illness. We had trauma patients who were homeless, and they needed a clean place because they had leg wounds and things like that. So that was actually really great. We've already talked about the de-isolation protocol. In August, when visitors were allowed, that sign there where it says escort required, you can see is for our visitors. The nurses would have to fit them for whatever mask they needed to wear and make sure they do their PPE appropriately. We obviously had more interaction with the physicians, the care managers, and the nurses during the multidisciplinary rounds. That's that MDR that you see there. We expanded the COVID team, and actually every single therapist at our hospital is now seeing COVID patients, which I am very proud of that and very happy. That's something in October that I championed for, that these patients need more. We need more people. The staff cannot continue to burn out. We want everyone to be able to help this population. And then we also had our fantastic Dr. Kudo, who is an infectious disease physician, do a in-service for our staff to further educate us about COVID-19. She is just so amazing and incredible. She loves rehab. She loves taking care of these patients. She's such a great asset to Orlando Health, and she really gave us a wealth of knowledge. So we appreciate her so much, and that was great for us to be able to have.
And I also think it was important for when Dr. Kodo talked to rehab for the people that were just joining the team, it just put their minds at ease. Because, Katherine and I, we were seeing these patients all alone. So, for months. So it was like nothing, just a day at work. But these rehab therapists were still so nervous about, are we going to get the disease if we see these patients? So, and just kind of explaining the different tests and how sensitive they are. So that was definitely such a good thing that Katherine set up for us.
I think on an average though, in terms of speech pathology, we get at least still about 1 to 2 on caseload per day. So that's obviously not a sustainable thing. If there's not 8 or 9 of us on a given day, and each of us have 1 or 2, one person simply cannot manage that. And that was never really the case with us. We're all kind of go-getters and dive right in.
Sure.
Vickie knows.
Any other questions?
We go to our last slide.
Oh yeah.
We need our last
forgot.
slide.
Yeah,
Oh,
we do need the last
So
slide.
sorry.
That's not your fault. That's mine. We're just dorky and we like it.
Stay home. I'm sorry for any errors with the slide advancing. My little arrows disappeared.
Oh, that's all right.
I'm going to check the questions and answers in the chat and give you all some additional questions. Thank you so much for just an amazing, amazing presentation. Let me just check here.
I just want to say on behalf of the College of Health Professions and Sciences at UCF, we are so grateful not only for this presentation, but for the way that you care for our community. We really all learned quite a bit from you from this presentation, and we can't thank you enough for sharing your expertise with us.
Well, thank you.
Thank you so much. It's truly an honor.
Yeah, I just want to say kind of as like, I guess, a closing statement, just for those of you who are obviously going to be practicing and things like that, that I think rehab is really special. I mean, I'm very partial, but rehab is so special, just how much the patients appreciate getting back to just living their daily life, whether it's PT helping them walk or get out of bed, or it's speech helping them eat or communicate, or OT helping them shower and brush their teeth. God, you don't know how many people didn't brush their teeth for 2 weeks till I came in the room. So just those small things, they really appreciate it. And we're able to, in acute care especially, because these patients are so scared and so sick, just get such a close relationship with them. And I think I would just encourage like future clinicians to just maintain your passion for what you do and remember how much it means to them. And, you know, don't be afraid to advocate for your patients and get them everything that they need so that they can try to have the best shot as possible.
Wow, what a powerful, powerful statement. Thank you all so very much. I'm not seeing any additional questions, just lots of wonderful chats thanking you all for this amazing talk.
Thank you so much for having us. We're very passionate, the three of us, about it.
And go next.
Absolutely. Thank you all so very much.
Yes, thank you, Vickie. It was a pleasure seeing you.
Yes, it's so nice to see you.
all.
Oh wait, there was one question right there at the end.
I don't know.
Right here.
Oh, Shailene says, I recently saw a story about a patient who twice while in a coma will have no knowledge of the pandemic. Do you guys have experience working with patients when they come out of coma?
So I don't know if it's getting COVID twice. It's
not a coma per se, but the patients are heavily sedated and placed on paralytics. And the paralytics are typically to prevent the patients from fighting the intubation and keeping them calm throughout their stay. So
I think they're saying someone before the pandemic was in a coma, like a GCS switch 6 kind of thing.
Oh, not related to COVID-19? Oh. I don't know.
No, we haven't had that.
Yeah.
Nope.
But it's not really getting COVID twice. The one particular patient that I was talking about with that used the Toby device, she had tested positive back in October and came to us in December without giving too much history away for her. She came in December and she was still positive, and they don't believe that it was that she was reinfected. They believe that she had really never went away.
There have been some reinfections. it's infectious disease's job to determine whether it's a new infection or just an exacerbation of the old infection.
And that was this one.
I would say I've maybe seen 4 confirmed reinfections throughout the entire pandemic in a chart review per infectious disease. So, and that's where it's been greater than 3 months since their initial illness. And suddenly they come in. We had a pair of twins, actually, 21-year-old twins who worked at Universal. They suddenly got very sick, and they believed it was actually a reinfection because their old infection had been about like 4 months prior. So.
Yeah. Her, in this woman's case, it was October to December. She was,
Yeah, it was only a
it was
couple
still
months.
the same one.
Yeah.
Interesting. Wow,
Thank
thank
you
you for
for all of
catching
our
that
panelists.
question.
Yeah, thank you for joining us today. And we'll put this recording out on our YouTube. If anyone wants to share it afterwards, check the College of Health Professions and Sciences YouTube. Thank you, everyone.
Thank
Oh,
you.
you too.
Thank you so much.
Bye.
Bye.